Okay, here's an interesting case that I saw recently. This is a bull mastiff that presented with a pleural effusion and pulmonary hypertension, and subsequently was found to have a heart-based mass. This was a 9-year-old male bull mastiff. He presented over the weekend with dyspnea and a pleural effusion. He improved clinically post-thoracentesis. He was then sent for echocardiography for further workup, and this is what we found. So this is a right parasternal long axis view that you can see here, and quite clearly there's a mass around the root of the aorta that you can see. It also seems to be in this view occupying a large portion of where you would expect to see the left atrium, and if you look, you can also see that there's a pericardial effusion, small volume pericardial effusion as well. This is a right parasternal short axis view, optimized for the aortic valve, so you can see the Mercedes-Benz in the middle, and quite clearly there's a huge mass sitting at the root of the aorta on that short axis view. So here we have the right parasternal short axis view optimizing the left ventricle. My eye was drawn to this, especially to the interventricular septum, because there was evidence of septal flattening in this case, and I felt that there was evidence that the right side of the heart was enlarged. So I was looking for reasons for right ventricular hypertrophy or right ventricular dilation. So with the colour flow Doppler box selected and placed over the tricuspid valve, it was quite clear that there was evidence of tricuspid insufficiency, and there was dilation of the pulmonic valve, annulus, and the main pulmonary artery. Continuous wave Doppler sampling of the tricuspid regurg jet produced a TR velocity of 4.5 meters per second, which is equivalent to a right ventricular systolic pressure of 81 millimeters mercury, and that would be consistent with severe pulmonary hypertension. So my next question was, where's that coming from? Is it related to the mass? And you'll see the answer to that in the next slide. This is a right parasternal short axis view optimizing the right ventricular outflow tract, the main pulmonary artery and its right and left branches. And what you can see quite clearly here is that the right and left branches of the main pulmonary artery run right into the tumour, which is what's compressing the branches of the main pulmonary artery, and that would be the reason for the pulmonary hypertension that's observed. So what you can see here is a right parasternal long axis view this time, just trying to optimize the aortic outflow a little bit further so that you can see the location of the mass, and that's shown quite nicely with colour flow Doppler on the next view as well. So this is the same view, the right parasternal long axis view, just with the colour box added so that you can see the flow through the aorta and aortic outflow, and so you can see the relationship of the mass to the root of the aorta. And this is just the left apical 4-chamber view, just so that you can see the mass from a different angle. So in terms of differentials for heart-based masses located around the body of the aorta, the most common one that we see by far is chemodectoma, and these are commonly found in brachycephalic breeds. Boxers are a breed that springs to mind in my view. There are other things that cause heart-based masses. Thyroid carcinomas I've seen, and they're reported in 5 to 10% of heart-based tumours, and there are some others as well which I haven't mentioned here. Well, that's it. Thank you for watching. I hope you found that useful.